Welcome to the Medical Collective, your go-to podcast where medicine meets real life. I'm Dr. Keisha Davis, a pathologist, personal trainer, and your host. I will be joined by a vibrant team of doctors who are not just healthcare professionals, but artists, fitness enthusiasts, and advocates for change. Each episode, we dive deep into the world of medicine, from untold stories of the healthcare industry to the latest in medical advancements. We're here to bring your insights, answer your burning questions, and explore the art and science of healing. So let's get started and step into the world of the Medical Collective. Hello, everybody. Welcome to another episode of the Medical Collective with me, your host, Dr. Keisha Davis, pathologist, personal trainer, and the host of this amazing podcast. We are doing a deep dive today in AI, and I'm excited, y'all. So first of all, today was a day. This was my off week from locums, which is my contract work where I travel and do pathology work. And I've been trying to get a lot done as far as social media, as far as the podcast. And I'm proud of myself, y'all. I'm proud of myself. I did a photo shoot for the brand today. I put some content together for social media, and I decided I needed to do another episode. I'm so excited about this because I have for probably the last 3 years since ChatGPT, became a thing, I've been really deep into AI in medicine. And I found out and already knew it's a lot more than what we call generative AI, which is the chatbots. And it's actually been in medicine since the 70s as far as microbiology goes. But I really found this passion in it when I found out what it's doing and helping in diagnosing cancer. And that's what we're actually going to talk about today. So I hope all you listeners, you're enjoying. If you're moving your body while you're listening, that's great. If you're walking, if you're jogging, I love it. If you're doing some yoga, I love it. If you're sitting down, just relaxing at the end or the beginning of your day, that is welcome as well. A nice calm mind, because this is a nice, happy, good, positive episode on what the future can do. So we think about AI. I know a lot of people are scared, right? Because there is this potential that, is it going to replace my job? I think we're going to have to start to rethink our jobs. And even me, I was like, oh, there's no way. I mean, I went to all these years of schooling. What I do is so specific, and the expertise and training is a lot. How can a robot or an AI machine replace it? And it can. But I think what we forget is that, first of all, artificial intelligence, or AI, we actually consider in science augmented intelligence. So it's going to help and improve what we're already doing, not replace it anytime soon, to be honest, not anytime soon. But the doctors that know how to use AI are going to be the ones that are going to be the keepers. We're going to be able to be in different positions, not just sitting under the microscope or diagnosing all day. So that's where really the future of medicine in pathology and other parts lies, to be honest. So let's get into it, y'all. Let's get into it. The first part I wanted to talk about is something called spatial biology. Now listen, I know we want to keep things basic and what biology is. Everyone took biology, right? In high school, were you asleep? Were you awake? Well, what I'm talking about now is taking the biology of a tumor and now being able to see it in a complex system, okay? If you remember, let's get to the basics of biology. Your body's made up of cells, right? And then cells come together and can become tissue, right? And then different tissues come together and make an organ. Okay, that's great. So let's do the liver, for example. The cells that help synthesize all the hormones that we use, those are the liver cells, but there's also things called the portal triads. There are blood vessels. There's also a matrix, which we call the stroma. So all of that together makes the organ, the liver. So say somebody has liver cancer. What happens now is a piece of tissue is taken and it comes to us, the pathologist, and we look at it under the microscope and we say it's liver cancer. Back in the day, I'll say that, or how things originally were done, once a biopsy was done, We decided it was cancer, and then there was a standard treatment. Now we're getting into precision medicine. Precision medicine is not everybody's the same, not every cancer is the same, and therefore we need a specific diagnosis based on that. And they truly believe that this spatial biology, which is now taking the tumor, so taking that biopsy, and now finding out what the microenvironment is. What proteins are being expressed? What are the cancer cells doing? Is there a lot of blood vessels? When you find out the microenvironment, you're not just attacking the tumor, but you're now seeing, is it a vascular rich tumor? Are there certain proteins that are expressed that we also can target? So now it's spatially finding out the best way to target that tumor. And I think it's amazing. And it's actually working. There are some places that are actually adapting this. Queensland, a spatial biology center, has used this 3D, which I think it is like a 3D tissue mapping on head and neck cancer biopsies, and it identified 600 biomarkers with clinical relevance. So the biomarkers, and for those that may have had a breast cancer, you've heard of triple negative or triple positive. That's the estrogen receptor, ER, progesterone receptor, PR, and HER2/neu. Those three are biomarkers. If someone is HER2 positive, then there is treatment like Herceptin that can target the tumor. So the same thing that's going on with this 3D spatial biology is now they can find the biomarkers and now have a customized treatment, not just based on one biomarker, but multiple, and how can we target the tumor? And you know what that means. The day-old use of just standard chemotherapy will be obsolete, which is great. As someone who has had a loved one that had to go through chemotherapy, it can have toxic long-term consequences. So I really think that having this targeted therapy is amazing. Now the C word, cancer, is a thing that unfortunately we're seeing more people with, but we're also seeing the older people living longer with it. So this is great. So that's how one thing. So what will happen is they use AI technology and these sequences and these codes to help detect the tumor, understand the tumor, and how to treat it. So I'm excited about that, y'all. The question that people have asked is, does it require tissue? They're thinking, oh, is it like an MRI or imaging? No, it requires tissue. So you still have to get a biopsy. But unlike traditional pathology where I look under the microscope and say it's cancer, that's a toy microscope I have behind me that I had gotten from my daughter, and I use it as a prop, but the real microscopes are much bigger. Unlike the traditional pathology, it uses protein expression, what we call, you've heard of RNA before, mRNA, messenger RNA, signatures of genes, all kinds of things, the tissue architecture around it. It uses all of that together with molecular analysis, which is the molecule analysis, the immunos, which are the special stains that we use in the laboratory to see what the tumor is staining for. It's a hybrid of that. And I think it's great. I think it's great. We still will need a pathologist. You know why? We still have to diagnose the cancer, look at it in the microscope. We also have to facilitate it. We also have to be there to make sure it's working right, to check it. Are the answers correct? Are they matching up? So I still think pathologists are still necessary in this. So this is going to be the personalized medicine we talk about. Spatial biology, y'all. Spatial biology. So right now, where we are with that is it's still in research phase. They are working on what we call clinical trials. So once something is in the process of, let's try it out, let's use vaccines, for example, they go through clinical trials. And clinical trials can last years. And then we look at the research, the data, and decide if it's something we can adapt to and include in our treatment. Also, something else that we will, and I'll continue to talk about is it affordable? Is everyone going to have access to it? That's important. Okay, something else I want to talk about, which something I personally have been using, And FDA, the Federal Drug Administration, has been clearing some tests for us. And this is in digital pathology. One of them is called the Philips IntelliSite. Okay, the Philips IntelliSite was the first whole slide imaging system. This literally what happens is I have behind me glass slides. And traditionally, we would, and still many pathologists do, we get in the morning a tray of slides and we look at them. And that's where the tissue is sitting on after it's been processed by the histotechs. And thank you, histotechs. What happens in digital pathology is pathologists are not always available at a hospital system. And what you're looking at could be something so specialized that it requires a consult. Instead of waiting, what we call the snail mail, right? With the mail who writes letters anymore. Well, why are we still having couriers drive from site to site or shipping stuff when we have this computer? So the digital pathology, and it's very similar to digital radiology, which has been a thing. And my father used to actually sit at home when we were younger and look at scans from the computer. So it can happen. It's been doing, radiology is ahead of us. So in pathology, the slides are scanned into a system and you can look at them. Now, what that allows you to do is now use AI, because now it's on a computer system and now these AI algorithms can detect things. And one of the things I was working on was with breast cancer and prostate cancer. What we know, what the problem is that we see sometimes my diagnosis is not the same as someone else's. And so sometimes things may just be a little bit different as far as the grading or the amount of tumor. So with AI, if you start to train it, and this is pathologists looking over and over and over again, some of these systems are pretty good, you all, pretty darn close to the prostate cancer diagnosis or breast cancer diagnosis as a pathologist. And so I think that this will speed up. This will make us better, more accurate, because it's like an extra eye. It's not replacing my eye, right? It's on top of my eye. And I just think that's amazing. There was a meeting that I went to, and one of the pathologists who's been using this has shown that they detected 20% more prostate cancer. So just think about that. That's how it's helping in digital pathology. The IntelliSite scans, and I was talking about the IntelliSite, it scans entire path slides into this high resolution. That's another thing. I'm Gen X, so I'm still in that age, but a lot of older pathologists are stuck in the way that they need a slide in their hand, and nothing can look as good as the slide under the microscope. And those of us that are transitioned, and I've seen both sides, and those newer pathologists or our trainees, they understand how amazing digital is, and they feel fine with it. So we do have this issue where in pathology and other specialties, when you have a lot of older trained physicians, you've got to try to get them to move on to this new technology, because they're the ones who are diagnosing the cancer. They're the ones that are over these institutions and making the decisions on buying the equipment or not. So you've got to convince them. Hello, listeners. We want to remind you that you can catch The Medical Collective on all your favorite podcast platforms. That includes Apple, Spotify, and YouTube. Be sure to hit that subscribe button so that you never miss an episode. We're also on Libsyn, and you can find us on all social media platforms as The Medical Collective. Do you have thoughts or questions? Please don't hesitate to reach out. We love hearing from you. Now let's get back to the conversation. So the Philips IntelliSite is going to replace glass slides, which I love. And there is an institution where I think he said he was like 50%. He plans by now, 2025 into 2026 to be completely digital. And you work faster. And then also, sorry to Dr. Sharon, who's OB, and she can't sit at home because she has to deliver babies, but it allows doctors, pathologists to be more flexible too. and a quality of life. And I do believe when you have a happy, just like happy man, happy wife, or happy wife, happy man, vice versa, it's the same thing. If you have a quality life with your physicians where they're happy, they're going to be more productive as well. And what I've heard from a lot of pathologists in the groups I'm in is they are ready. All of them are like, oh, is there a digital pathology position? Can I work from home? I mean, they have kids. I can think of the times that I may have, especially during COVID, when the kids were at home. Do you know how hard it was for us and how bad I felt and I had to leave? And I wish I could have been there, but I could have done this from home. So digital pathology is going to afford that for us. Also, for those rare liver cancer cases, I had a case that I was not, and this is another thing about a good doctor, is you know when to defer or get a consult, and I have no problem asking, is that on those consult cases, instead of waiting for sometimes 4 or 5 days for transport and all of that, is that you can flick it on, you can call them. And even sometimes when we have a rapid diagnosis, when the surgeon is waiting for us to do a frozen section, which is a rapid freezing of the tissue, looking at it right there so that they can decide if they need to change their surgery, is that we could have something we're not sure about and we could just flick on the microscope, flick on the computer and send it to our colleague and say, what do you think about this? So that's the beginning of what digital pathology can do. So I'm excited. There was something I wondered though, and many of you may not know as much, but if you've had cancer, some of you may be told to go to a medical center, right? Or some of us live in smaller towns, is that there's a difference between how people practice in academic medicine because everything's there. You have trainees, you have the money and the funding to be able to do a lot more research on specimens and patients and what have you. In private practice or in smaller areas, they're focused on patient care, but they're not all doing tumor boards like a larger center is. They don't have trainees and they don't have the ability to just try a lot of new things, right? They're sticking sometimes to what they've already have and what's working for that center. So the new technology, the digital scopes, they're not going to be there. They're going to be at the medical centers. And that's just, unfortunately, that's the way it is. I wish that they were more adopted. I think time will tell, to be honest, time will tell. Adoption is increasing. There are countries, not in the United States, that actually are adopting it more. And one of the things that I saw, and this was when I went to the same conference, was they had a video. Okay, I don't play video games, but how cool would it be? They have these chairs, and there's literally a lab, I think it's Australia, that literally has chairs that look like gaming chairs. And it is a, not 360, but half 360, literally a TV screen that folds and it arches like this. And you can look at the slide almost in 3D. Yeah. So while the doctor's sitting in the chair, leaning back, and they have these in their offices, they have this screen and that's how they sign out. And then they literally have they can even have a joystick where they're deciding remote control, what to do or circle something. All of that. Yes. So it is happening places. Internationally, adoption's higher. Netherlands and Sweden are 2 places. As of 2024, there were over about 200 pathology labs globally that were using some of these, like the Philips IntelliSite. So we shall see. And I do believe, even though we have the resistance of older pathologists with change, we just got to keep pushing because what they're going to see, and my friend was saying this, is that you can either hop on the train or you can wait when it passes and then you're trying to run to catch it. It's that simple. AI is here. Digital pathology, digital radiology is here. Advanced technology in medicine, robotic surgery is here. So if you learn it and accept it, you're going to be doing a service to the patient and to yourself with job security. Yes. So that's where it is with digital pathology, everybody. So when we talk about AI, And I was talking to my husband the other day because he likes sci-fi and I don't. I do not like science fiction at all. He's like, well, we need to be careful with AI because it's going to take over, and it's going to be us against them. And I don't think about it like that at all. I have always been an early adopter in medicine and beyond, and I embrace it, to be honest. I really do. And I think that's one of the fears. So you can have all this great technology, but is it going to be adopted by doctors, right? Are they going to have a fear? Are labs going to be adopting it? And we're talking about the US, because there are places that are forward thinking. That's one of the concerns. And I think is it going to replace us? And it's not. There is this AI tool, and this is something else I saw. This is something that many of you may not know. If you go to the ER and you're really, really sick, your baby's sick, or you're in the hospital and you have a high fever and the doctor says, oh, you have a high white count, your white cells, your cells your fighting cells, your white blood cells are very high. What happens is if it gets flagged because the count is higher than normal, then a pathologist, will look at it under the microscope, and that's called a peripheral smear review. Now, same thing, a slide has to come, and then usually what happens in the middle of the night. Unless it's really, really urgent, then you're waiting till the next day for me to review it. Or if I'm at a different lab, it has to be sent to me, and all that takes time. Also, the slides are not cover slipped when they're the blood smears. And so when you see something like, oh my God, out of all these hundreds of cells, I think I see what is called a blast, a tumor cell, a leukemia cell, and you can't dot it. Well, this AI system, and this was so neat. It literally was digital pathology, so it was up on the screen, and then they had a algorithm that detected cells, and you could also circle them. So say, for instance, this is why I love multiple eyes, the lab tech looks at it first, and then they circle the things that they're concerned about. Then the system as well, that's the second eye, is looking at it and saying, I think that's a blast. And I want you guys to know it can be that hard when you're looking at a smear of blood that there could be maybe 1 or 2 blasts, which are these precursor cells that should not be in the blood and usually denote something going on, including leukemia. But if you have a system that is now helping you catch those, and then you have the tech catching those, and then now I'm the third eye looking, and I agree, and I'm at home, and it's getting done, and we're calling the doctor because acute leukemia is important. Treatment needs to be started right away. So that should not be a fear. That's not going to overtake us. That's actually going to help us more, and again, help the patients. That is one of these that's been in use, and some of the companies are trying to sell it, and I think it's great. I think it's a great tool. The Lunit scope was used in breast cancer, and it was helping detect micrometastasis. So when you find out you have breast cancer, your lymph nodes are checked. So if you have breast cancer on the right, they check your right lymph nodes, the ones that they believe are the first ones that may be draining from the breast. And they look at them under the microscope. Well, this Lunit scope has an algorithm that it can detect a metastasis that's very small, like a millimeter small metastasis, and then also can predict gene expression profiles. Remember, I talked about the precision medicine, so being able to find out what your environment is of your tumor and how we can attack it best. So that is what the AI is doing, and it's working. There's another one, Halo APDX, that's also using AI to accelerate and triage abnormal things, which is great too. Another thing we do sometimes, we have a whole bunch of cases and we need to triage what we need to look at. And sometimes the thing you think is the most normal, like a GI biopsy, that even sometimes the doctor was like, oh, there was just a polyp and ends up being cancer, is you don't get to treat, you don't know. And that could be the case you look at the end of the day, and then by then, histology has their cutoff and we can't order special stains. But if you have a system that can take everything, all my work, and scan it, and then kind of flag it by what I should be looking at, I think that is amazing. Amazing, amazing, amazing. Something else is on breast core biopsies, the AI, this other AI system can flag sentinel nodes. And I mentioned that because they were flagging sentinel nodes as positive, where on initial review, manual review, our eyes missed them because it could be that small. So that's AI caught that, what we missed. Colon polyp as well. There is sometimes variability in what I say is a high-grade colon polyp versus someone else. And AI, because now AI is using the GI pathology experts, right, in their eyes and training themselves over time to now be able to reduce what we call inter-observer variability, which is important. So it's improving detection of adenomas. Great thing. Another AI algorithm is prostate biopsies, and this one identifies high-grade cancer earlier than routine screening. And I mean, what else? Especially when we're hearing about a lot of people having prostate cancer. So doing the biopsies is one thing, but making sure the accurate and complete diagnosis is the part that we are dealing with, and AI can help us, not replace us, but help us. I wonder how people feel about that. I think that explaining this may put you at ease, right? Because when you hear AI, you think about ChatGPT, people cheating, these AI pictures that look like us, people getting scammed by AI. But what about the AI that's helping solve problems, helping us diagnose cancer, helping us find the correct treatment through this spatial biology for a tumor, to treat you so you don't have to go through this painful chemotherapy? That is what we need to be thinking about as far as AI. Now, the fear of replacement, I don't think it's anytime soon. And it is the combination, again, I think of this as not as artificial intelligence, but augmented intelligence. And this is improving outcomes. The data shows that AI plus a doctor, I mean, this is now a team. We got our team, that it is improving outcomes in detection and treatment. It just is. Countries like Netherlands, UK, South Korea, they're using digital pathology and AI, and their integration's more advanced. And I think we can learn from that, to be honest. In the United States, the legal liability is one thing. If the AI misses something, who's responsible for that? So that is really where the pathologist has to be the overseer. That's where someone that's not trained cannot just come over and say, oh, now I can have an AI lab. And CAP, who accredits laboratories, who checks to make sure, who does the inspections, they're not going to have that. We still have to have pathologists diagnosing and releasing it. So also seeing how that's going to work as far as signing out cases, and also reimbursement is something. So right now, trying to get reimbursement for that is difficult. That's something also to concern. Ethical concerns as well. I think that with any AI, is this going to be something now that's easier for people to get access to my information because you're using this computer system? I think it's very similar to other hospital systems, which have a lot of ways to protect that data. And then bias. So we've heard about biases in healthcare. If you're taking the same information, and let's say, for instance, there's something, we've heard about this with the GFR, which was a measurement used for kidney function, the filtration rate, and that it was not, there was a different measurement or way it was being assessed for people that look like me. So the question would be, is this going to be biased? Is this going to help all patients? And I think one thing, in order to train a system, you know what we have to do? We have to have data, and we have to have patients and all of that. And it has shown that when it comes to research, that there is less diversity in research because of mistrust. There are less people that look like me doing the research, but also bias on how the system, if you're already thinking, let's say, for instance, there's a specific type of pathology, dermatopathology, which is skin. Let's say that just a bunch of people that just look at hematology all day, which are blood-related tumors, decide to feed the algorithm for skin. It's going to be biased because these people don't normally see skin pathology. So therefore, also the results could be skewed as well. So it really requires that we have to make sure that the system that's feeding it, we're making sure it's free of biases in all ways. And we have to make sure we also have data that represents the population, which can be hard to get sometimes, unfortunately. I also do like something that was mentioned, is that there has to be transparency. These are companies selling these to doctors. There has to be transparency in how the information was gathered. The doctors have to feel comfortable with it because they are the ones. There is one AI system that I saw at one of the conferences, and you were able to actually train it yourself. So you were able to use their algorithm, but also kind of change things or say you agree with something, so you're retraining it as well. So there is that possibility. So that also leads to more trust, right? Because now you're like, okay, it accepted this. Now I feel more better about it. And now you have this better relationship with your AI system. Yep. Very, very good. So there is still a lot to work out. I think that the medical centers, the larger institutions abroad are doing it. I think we need to learn from them. And I just hope that it's not just the medical centers, but these smaller, because a lot of patients start in smaller places, small hospitals, rural areas, are getting diagnosed with cancer, that we also have the access to it. So we really need to push for the older physicians, those in smaller places, to understand that digital and AI in medicine and pathology is necessary and vital to patient care. I hope that helps you all. The key takeaways I would tell you all is that it is the future. It can be harmful in the wrong hands. Very true, in the wrong hands. But in the right hands, it's going to save lives, and it is and has saved lives. And it's helping in making our diagnosis and our life and our practice better. So if you have any questions, I will have some resources in the show notes for this. You can always reach out to the Medical Collective with questions, because we will be doing a new feature on just answering your questions. But in the meantime, everybody, continue to listen to us. Next time, we have a very special episode as well. And I hope you all have a happy day wherever you are. Stay tuned. Thank you for tuning in to the Medical Collective. We hope today's episode has left you with valuable insights and a new perspective on healthcare. Don't forget, follow us on social media for more updates and behind-the-scenes content. I'm Dr. Keisha Davis, and it's been a pleasure to share this time with you. Stay healthy, stay informed, and we'll see you in the next episode, where medicine continues to meet real life. Please note that the content provided in the Medical Collective podcast, including text, graphics, images, and other material, is for informational purposes only. The content is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified health provider with any questions you may have regarding a medical condition. The views and opinions expressed on this podcast are solely those of the individual authors and guests and do not represent those of the Medical Collective, its staff, and any affiliated entities. The appearance of content on the podcast does not imply an endorsement. Neither the host, Dr. Keisha Davis, the co-host, or any guest of the podcast bear responsibility for the accuracy of the content provided or the use of information received through the podcast. Reliance on any information provided by the Medical Collective podcast, its employees, writers, or guests is solely at your own risk.